I did at Oxnard Medical Center. I was there for residency for 5 years. I did 2 years of interventional neuroradiology. And it was at a time I did my fellowship in 2012 to 2014, and stroke was just coming into being the thing to do. We had early devices we helped develop. The neurologist did not believe in thrombectomy. They kept saying it didn't work. It didn't work. So at this point, it was still kind of experimental, even until just about 3 years ago when there's actually level one evidence to remove the clot. So, it's kind of like now it's the thing to do. But early on, when I was a fellow, I was the only fellow in Louisiana. In Alabama, Mississippi, all the states would send us strokes. So we did lots and lots of strokes, a lot of experience. And essentially what they developed and what BayCare is kind of developing and has actually was a hub and spoke model. So this plan of managing stroke has been going on for more than a decade. Europe is really good at it because they have one big centers everywhere. They don't really have hospital competition. Here we have hospital competition. It makes it difficult for us because hospitals tend to want to keep patients. EMS go to certain hospitals, and a lot of money and politics are involved. You can even go back and watch this old thing on Cinemax called The Nick, and it's a good 2-season series, shows you about how EMS and early on medicine in America, but it still applies today. So much so that our society has actually gone on to make it a law for certain people to not take patients to centers that can't do a thrombectomy. This is going on in Arizona as one state and other ones, and they're following the model for STEMI and trauma because by law, you can't take those patients to certain hospitals. This doesn't exist for stroke. Even today, you have a stroke in Pasco County, they're just going to the nearest hospital and get on a helicopter and hopefully come here. But every transfer results in a loss of brain tissue. Okay, so there's Comprehensive Stroke Center, there's Joint Commission in Florida, there's different metrics. We have a DNV certification at our hospital, and the only reason we do Joint Commission is because they make it so hard that's really for academic places. They make it almost impossible for small private community hospitals, or even large ones, to get their certification. And so, but they're when they come here and survey you, we actually pay them to come tell us what we're doing correct or wrong. But they talk about ischemic stroke and hemorrhagic stroke. One's urgent, one's emergent. And what I mean by that is acute ischemic stroke is emergent. It has to happen right now. Every second you lose 32,000 neurons. That's like 1.8 million a minute. And it's like a melting ice cube. So it's imperative. It's really important to get to a correct hospital. If they're taking your family to the wrong hospital, you're going to lose time. And every average transfer loses about 90 minutes, and your outcomes go down by 10% every 30 minutes you wait. So you wait that one transfer, you have a 30% less chance of a good outcome. So it's really important to get to the right place. And almost like more than 80% of the geography in America, if a patient has a stroke, doesn't have access to a thrombectomy capable center. And you just have your stroke and that's it. So AIS is really a time for what I mean by acute ischemic stroke, because it's not stroke we say stroke, and we're really talking about acute ischemic stroke. There's hemorrhagic stroke, but that's kind of a separate thing. That's usually ruptured aneurysms, and I'll get to that a little bit later. And this is this diagram here shows a collateral score. And we don't really talk much about this in any of our papers, but it's something to understand. And the most important thing is this collateral score will determine how fast your brain dies. As soon as a clot hits, it's like a melting ice cube. Well, if you have a collateral score of, let's say, 0, this stroke is going to be completed in 30 minutes, meaning the tissue at risk will die. You have a stroke scale, score of 4, you can do a thrombectomy 1 day later, even 24 hours later. So this whole time of onset thing is really kind of irrelevant in the setting of perfusion imaging, because we have the ability to know whether there's at-risk tissue or tissue that's dead. And that will change in time, because there was actually an article in New England Journal published this past month saying that it doesn't matter whether the brain's dead or not. If you pull the clot out, patients do better. The Japanese did this paper, had about 200 people in it, and it's kind of borderline ethical and moral, but they proved it. And what's going to happen down the line in about 5 to 10 years is we're going to take every clot out of the brain. We already do that kind of now. It takes a while for evidence and guidelines to come to be, but you can imagine that perfusion imaging down the line will not be the reason why we say yes or no to a stroke. It's just going to be if there's a vessel occlusion. Perfusion won't go away. It'll still be a tool to know if there's ischemia or infarct or how bad it is prognostically. But down the line, we're just going to see a clot and we're going to take it out. My partner already practices that way. So, and I was a level 1 evidence, and that was a change because that didn't exist. And they were not this year; they were earlier, a couple of years ago. But that was a big obstacle to this procedure. And and a lot of people don't understand before the ED. It seems like everybody should know, but not always. EMS doesn't always go with lights on, sirens on. I mean, if you look at the body language of people relative to a stroke and trauma, just an outside observer, and you can tell it's different. Almost every human being involved with stroke doesn't have the same body language as they do with the STEMI or trauma. And that's a hard thing to culture change to have. It should be the exact same, but it's not, and it still isn't. And it's a hard thing. Like I said, this takes decades sometimes to change that, but it needs to be treated like a trauma or STEMI. And in the NIH stroke scale, which is, we don't do often enough, and this needs to be done more often because it's the way to objectify, like quantify a stroke, which is a qualitative, subjective thing. But if you have points and get these, it helps to determine, how bad the stroke is. And right now we kind of use it to help determine if we need to do an intervention. If the stroke score is too low, a lot of times you may make things worse. But I mean, all of this is evolving. So, but stroke skills are very important. It helps us identify what we're looking for. Okay. So acute ischemic stroke in the emergency room, their goal, you just got to get the CTP as fast as possible. That's the perfusion study. So, that's absolutely the key. That needs to happen as fast as possible so we can determine whether they need to get the clot out of their brain. TPA candidacy is determined by strict guidelines that are 20 years old and, time of onset and whether there's blood in the brain. So that's why when you get a stroke alert study or the CT brain perfusion generally includes a non-contrast ED CT in the setting of stroke so we can comment whether there's blood or not and whether they can give TPA. Now, TPA in the history of every paper they wrote, it's never worked on a clot that's longer than 6 millimeters. And most MCA occlusions that are large vessel occlusions are longer than 6 millimeters. And so you kind of see that strokes are in two baskets. There's a basket where there's what we call LVO, large vessel occlusion, or there isn't an LVO. If there is an LVO, a large vessel occlusion, TPA isn't going to do anything. But the guidelines are still archaic and we still would give it. It doesn't matter, even though it does nothing. But remember, TPA strokes are usually ones that aren't going to have a thrombectomy and they may benefit from TPA. And like I was saying earlier, time of onset is just not important. It's not for thrombectomy and not for us. And it's like, I look at the perfusion, and if I don't, there's another alternative perfusion. I'll talk about that later here. It's called an aspect score. And I'll talk about why it came to be and everything. But CTP is the reason why time of onset's irrelevant for us in determining whether a patient needs a thrombectomy. And so, this is a kind of an older slide from our Society of Neurointerventional Surgery, call it SNIS. And these are kind of like just what they suggested for people to kind of get their times, ideal time for this and that. You can see the different parameters they try to get to. And we have our own set of numbers here at our hospital, at St. Joseph's Hospital with the stroke team, and that they're following, and in conjunction with the DNV certification. It's somewhere in the ballpark of all this. The point of this was not to say this is what has to happen. It just says kind of to show you what kind of details that you need to kind of notate to understand, and kind of like what the ideal time is. And everything's not ideal. It depends on your institution. Our times are actually very good here at St. Joseph's Hospital. Our stroke team, we accomplish tremendous times here. So this was aspect was what I was talking about. So this is a way to determine if brain tissue is infarcted or dead without doing perfusion imaging. This was developed in Canada because in Canada it's social medicine. They don't always have CTP machines, but they have the ability to take out clots. So they use a head CT and regular non-contrast to determine whether there's infarct. And remember, infarct and ischemia are totally different things. Many diagnostic radiologists incorrectly use that interchangeably, and to their defense, it's also in the literature incorrectly used. So, ischemia is definition of less than 30 milliliters of blood flow per 100 grams of tissue. So that's ischemia. That's tissue at risk but not dead. Dead tissue, infarcted tissue, gets 10 milliliters of blood flow per 100 grams of tissue. And so that's what CTP exploits. It exploits that exact amount, that number I said, ml of flow per 100 grams of tissue. That's how we figure stuff out. So if you don't have that, you do an aspect score. And you just see whether if the score is, less than 5 or less than 6, you tend to not treat those cases because of too much infarct. All that's going to change because the article published last week, maybe down the line, but there is another way. And a lot of people use aspects if they want to do more procedures, because this obviously will include more procedures into your group, because CTP will detect the stroke earlier than the non-contrast head CT. So these are the reasons why they used it, what the parameters they use, how they use that to judge cases and stuff like that. So, I mean, they have the time of onset within 3 hours. Remember, this is all a lot of this older. You don't have CTP now. So now you got to go back to rely on this older, notion of time of onset. And, like I said, they score it, and the score is easy. We're actually including in our reports. Here's kind of the scoring system here. So these are the non-con head CT, and you can see all those numbers, M1, M2, L, IC, each of those accounts for a point. And a normal head CT will have 10 points, okay? And so the M's means MCA territory, the C is the caudate head, the L is the lentiform, and the I is the internal capsule. Those are just anatomic structures in the basal ganglia. I is the insular cortex. But if any of those are not normal or down and hypodense, that's infarct. And if you have different territories, you can see where they are, and your score is like 6 or less, that's majority dead, and you usually don't do thrombectomy in those cases, or you don't right now. We will down the line. So this is a picture of one of the catheters we use. It's the A64, a company made Penumbra makes this. Since this catheter, there's been a lot of new iterations. 6.4 stands for the diameter of the interlumen of that catheter. It's 0.64 inches, the opening. Now we have catheters up to 0.72 with the same outer diameter. So basically, the catheter is just the same size, but the hole is bigger. And this keeps getting better and better. And everybody makes something, one-ups each other. Before, we used to use retrievable stents to get the clot out. These devices, like a stent on a stick, but that wasn't a great way to do it. This slide kind of shows you the evolution of stroke and what we've done. And, it started early on 2004 up to 2013, and all these various iterations we did. After 2013, things haven't changed much. We used aspiration. ADAPT it was a trial they had. They were trying to figure out whether a stent retriever would work. And in the trial, they randomized people to with or without a stent retriever. And what they found is when they put the catheter up, as soon as they turned it on, it sucked the clot out without the stent retriever. So the trial failed in the sense that they never got to use it because their catheter was so good. So it's by accident they kind of discovered the technique. But before, back in the day, they had this thing called a Mercy device that's on the top left. That's a brutal device. It didn't work. It injured the vessel a lot of times. Additionally, if you look at the bottom on the top left of that slide, there's a blue catheter. There's a balloon there. So you have to blow a balloon up in the carotid artery, block the blood flow, and then put this thing in the clot. And just like the stent retriever. Now imagine putting this thing in the clot. It smashes the clot. Little pieces go out. It's just not the best way. And you have to drag the clot all the way down into that little blue catheter. So things have gotten a lot better. Now we just put that catheter up and turn the machine on. It sucks it out. And it's gotten quite simple relative to before, and much more effective. We'll go through some cases here. So, on the right is a lateral image of a common carotid angiogram. All you see is the external branch on the left side, and you see a little pointy thing. That's the internal carotid artery, and there's not contrast going in. And it's not because there's a blockage there. It's because there's no outflow of the internal carotid artery. Once the internal carotid artery in the neck, the carotid bifurcates, there's not a single vessel that outflows till you get to the ophthalmic, which is what you're seeing on the image on the right. There's a plug. There's a clot above that. So once you take it out with that catheter, you're going to look like this. Okay, so we take the clot out only to reveal there's another clot on the left image there in the middle cerebral artery. So a lot of times we call them tandem occlusions. So a clot happens in the carotid and the middle cerebral artery. So with that tube, you advance the tube up, suck the clot out, and now you have flow, which is tremendous for the patient, because you can imagine all the blood flow was missing. If you go back and look here, you're missing all that blood flow that we restored here. And here's what the clots look like. Now, there's a lot on this because the patient had a clot in the carotid and the middle cerebral artery, but usually it's just one of those is the clot in the brain. It usually looks like something on the right, like at 3 o'clock on that picture right there. That's usually what these things look like. The catheter kind of deforms it a little bit to the shape, but they're little tiny clots. They're not very big. Another picture of a clot here. So we have a right MCA occlusion here, and there's the AP view, and the one image on the right is the lateral view. Well, there's a lot of blood vessels missing. And if I go to the next image, you'll see what was missing, what we got back. So you take the clot out and you have a vessel there and you have good revascularization. So, I mean, these are great things for the patient to get this clot out. And here's what that clot looked like. Look how small it is. The other clot was big. These are small. All it takes is a little plug. And this is a devastating thing because it doesn't lead to death. It leads to disability, which is arguably worse than if you're sitting in a nursing home disabled. Most people would rather not be disabled and be dead. So, I mean, this is a big deal for stroke because it's not like a heart attack where people die. It's you get disabled with a stroke. So pulling these clots out is huge. And now we'll touch a little bit on hemorrhagic stroke, which is the other arm of stroke. They go hand in hand, acute ischemic stroke, hemorrhagic stroke. They go hand in hand in a sense of that there's a neurological change, but the management, disease process, very, very different. So most hemorrhagic stroke are aneurysm rupture. Sometimes it could be an AVM rupture or AVF. AVM is arterial venous malformation. AVF is arterial venous fistula. It's better just to term them as vascular malformations. That's a better kind of phrase. And which mean urgent versus emergent. In a hemorrhagic stroke, the evidence says you must treat within 72 hours. So that's what the country uses, not the country, the world. The reason is after 3 days after rupture, you go into vasospasm. That's when it starts, at least. It peaks at day 5 and 7, but it's hard to treat an aneurysm once spasm is set in. In the United States, we tend to do it more of a 24-hour kind of treatment thing. So if an aneurysm comes in the evening, we don't rush to treat it. We wait till the morning. And it's because when an aneurysm ruptures, it only bleeds for a few seconds. You can't keep bleeding. You would die. The brain's in a closed box. There's only so much space. So you bleed for a few seconds. Your intracranial pressure increases and it's higher than your blood pressure. And so it's a pressure game. On one side, the artery is this number, the other side is that, and you don't bleed anymore. But now you're left with all the blood. You're left with, intense headache, increased intracranial pressure, and then the blood, which is not in the brain, it's on the surface of the brain in the subarachnoid hemorrhage. Remember, majority of the time, those blood tends to clog the resorption of the cerebral spinal fluid. And once it doesn't resorb, now you're making more fluid, but it's not resorbing. So you get hydrocephalus and you may need a drain. So a whole sequence of events starts from this bleeding, including vasospasm. So, once these people are in the ER, there's a couple of things they need. They need an A-line to accurately determine their pressure. Because you need to know you can't be hypertensive, you just ruptured, which is kind of the opposite of a stroke. And in an acute ischemic stroke, we allow permissive hypertension to allow the collaterals to fill. And, we don't correct it unless it's over 185. But in a hemorrhagic stroke, you want it low. And you want cardine. And you need cardine to stabilize the arterial wall. Cardine is a calcium channel blocker, and it stabilizes the wall of the aneurysm in addition to lowering the blood pressure. Consults need to be placed, needs to be a CTA, and then the Hunt and Hess scale is important in terms of prognosis. So we also have incidental aneurysms that we see all the time, and that's an outpatient workup. And I tell people too, they're blue in the face. I'm blue in the face, but nobody really seems to get it. Everyone's scared of aneurysms, but people have had these for decades, so you get calls all the time for incidental aneurysms. But a lot of them are found because we're looking for strokes. Acute ischemic stroke, we end up finding an aneurysm. So, in an ED patient, history of an aneurysm, what's kind of important is that, if you're on aspirin and Plavix, you really can't stop it. It's very important that we keep people on Plavix after a flow diverter. Flow diverter is just it's like a stent without radial force. So we put these in the internal carotid artery, and it's like a scaffolding for the internal carotid artery, and the endothelium develops over it, and it excludes the aneurysm from the circulation. But until that endothelialization occurs, you have blood touching the metal on the device. So the metal's negatively charged, platelets are positively charged, and they stick together. And until that thing is covered with the film of endothelium, you have to get Plavix. If platelets stick together, they make a clot, then your carotid is blocked, and you have a major stroke. So it's important with Plavix or antiplatelet agents. So here's a picture of an aneurysm. On the left, on the red, you can see that little nub on the bottom. That's the internal carotid artery. That vessel coming off straight to the right is the ophthalmic artery, because aneurysms tend to happen at bifurcations in the head. On the right is the angiogram picture, and you can see that little bump. That's the aneurysm. So here, this is a stent assisted coiling. So what was done, since a stent is there, you can barely see the stent, they're almost invisible. But on the other side of the stent, I put those metal coils, they're platinum coils, and they cause a thrombus to develop. And once the clot develops, the aneurysm is sealed or occluded. I had to put a stent in there because the neck of this thing is wide and coils would not stay in without something holding it up. On the image on the right, you can maybe see 3 little dots in the vessel. Those are the ends of the stent. This stuff's really hard to see because it's so tiny. And this vessel is 4 millimeters, the internal carotid artery, like most internal carotids. Here's a giant basilar tip. This is, angiogram of the basilar artery. You can see this giant golf ball in the head. This could, this is devastating if it ruptures. So we tried to fix it. We put coils in it. Okay, so you can see the ball of coils in there. A lot of coils in there. And again, you're trying to form a clot in there. Basilars are very hard to operate for a surgeon because exposing that is extremely difficult because the basilar is located behind the brainstem, below the brain, in front of the cerebellum. So exposure is almost so morbid. It's very hard to see, very hard to do, as opposed to like a middle cerebral artery aneurysm or an anterior communicating up in the front. Those are easy. This is very difficult. And coiling has gotten so good that there's very few neurosurgeons in the country that could safely and confidently even do basilar aneurysms anymore, because over the past 10, 20 years, everything's being treated endovascularly. So the skills of a neurosurgeon in regards to neurovascular clipping are decreasing, and the majority of neurosurgeons are very scared of doing these procedures or just don't do them. So there's another type of rare thing called a CC fistula, carotid cavernous fistula. It's a type of dural AV fistula. So a dural AV fistula is a vascular malformation. It's essentially supplied by the external carotid artery. If it's internal carotid, we tend to call them not that. And they're direct or indirect, and they mean just that. Direct is a big hole from an artery to the cavernous sinus, just one pinhole. Indirect is tiny, tiny spidery vessels going from one place to another. And, and it causes eye symptoms, your eye bulges, and, because imagine the veins are arterialized. They're under pressure from the artery because there's an abnormal communication. So here's a good picture of it. So if you look on the first image on the left is an angiogram where I injected it, and it's supposed to go in the head, but it didn't go in the head that much because it's all going into a vein. It's going into the cavernous sinus. You can see at 3 o'clock on the image on the left, there's those other blob stuff. That's veins. That's the orbital vein. You're not supposed to see that. And it steals blood from the head. It causes the eye to bulge. And in the middle picture, after I fixed some of it, you can see how the flow is now diverted into the cerebral vessels. And on the far image on the right, there's coils all around that in the cavernous sinus, because the one, anatomically speaking, this is only one part of the body where an artery travels through a vein. So the cavernous sinus is full of nerves. There's like 4 nerves on there from the maxillary branch, and the internal carotid artery literally goes through a vein. And so if you develop a hole there, it's not really life-threatening because it's artery to vein, but it arterializes all these veins, and they're supposed to be draining your head. So the blood can't drain properly. You get venous congestion, you get venous hypertension, and a whole cascade of events happens. So we fix these by putting coils into the cavernous sinus. You can get in there through the hole in the carotid. You can even, catheterize the vein on the left. You can poke a micropuncture needle above the eye, get in that vein, and put the coils directly into the cavernous sinus to stop that fistula. Okay, and this is the last slide I have for about interventional radiology, and I'll take any questions.
Right, that was awesome. I'm going to stop the recording that we can ask the questions. We have a couple of questions in chat.